This is A Better Night's Sleep, a podcast about sleep, sleep disorders, and evidence-based treatment from military health sleep experts. I'm Dr. Julie Kinn with the Defense Health Agency.
And I'm Dr. Jonathan Olin. I'm a sleep physician and medical director of the Evans Army Community Hospital Sleep Lab.
So, John, last time we started talking about CBTI, Cognitive Behavioral Therapy for Insomnia. You taught us about relaxation and sleep hygiene. And today I'd like to get back into it and learn a little bit more about CBTI. I know there's more components that we didn't have time for last time. But first, I wanted to bring you a listener question about caffeine. How long does caffeine stay in our system? And how much caffeine can we drink and still be engaging in sleep hygiene?
Sure. Well, those are good questions to start with. Caffeine has a half-life, which means half of it stays in your blood for, depending on who you are, 3 to 8 hours. So
that's a big range.
That is a big range, and some people are very sensitive to it, and it'll be longer in their blood. It is obviously alerting. It's used in large part because of that. People that are having insomnia or that are having larger amounts throughout the day, including in the afternoon and dinner, that doesn't make a lot of sense. They're ultimately alerting themselves. And we know that there are people that say, hey, I used to drink 6 and I've cut back to 3 and I'm just having now 1 at dinner. Okay, better. But that's not ultimately helping those sleep-inducing parts of the brain then work effectively.
Because it's at night, you mean?
Yes, exactly. So they've reduced it significantly, but their last dose of the caffeine is still in the evening. So that means even if they're a quick metabolizer, say they're a 3-hour metabolizer, and half of it in their blood is gone, and they're having one Monster or 1 cup of coffee at dinner, say even at 1800 or 6 p.m., that's the equivalent of having half a cup of coffee at 9 p.m. or 2100.
Right.
So why would someone with insomnia say, you know what, I want to have a half a cup of coffee at 9 p.m.? They wouldn't.
I hear people say, yeah, but I've been drinking coffee for so many years, I'm just used to it. It doesn't affect me anymore.
People can develop a tolerance, and that's absolutely true. But insomnia is often an issue of straws on a camel's back. So there may not be one crucial issue. There may not be only coffee. They may have diploid. They may have relationship problems. They may have a habit component where they've had insomnia for now 6 months or a year. They may be glancing and looking at their clock throughout the night. So their job with a clinician, but their job is to gradually peel away these straws. Caffeine for some people is more than a straw. It may be a brick or two. In general, in sleep, we like 1 or 2 caffeinated beverages a day, or not more than, both before noon. Then if you're a long, slow metabolizer, it's still very much reduced.
So I guess I hear you saying we are going to react to caffeine differently depending on our habits, probably our age, our body type. And if you're one of those people who say, well, I drink caffeine all the time, it doesn't affect me, and you also sleep well and don't have insomnia, then great, no problem. But if you drink caffeine a lot and you also have insomnia, then it's probably worth trying to cut it back to before noon and doing that for a long period of time, at least a few weeks, to see if it does play a role in the insomnia.
Exactly. And to further clarify, I generally recommend a 10 or 20% reduction per week. So if someone's drinking 10 cups a day, I'm not going to say you need to cut down to 2 tomorrow.
That's fair.
Then they're going to be in withdrawal and have problems. So in that case, they go down to 8 or 9, do that for a week, 7 or 8, do that for a week, etc., and gradually get down to the 1 or 2, both before noon.
Thank you. That's helpful. And please, listeners, keep sending us your questions. We really want to stump Dr. Olin. Okay, so, John, tell us more about CBTI, Cognitive Behavioral Therapy for Insomnia.
Great. So earlier we talked about relaxation technique and sleep hygiene. I view it as 2 other significant components to CBTI, and this would be stimulus control and then sleep restriction. Stimulus control refers to not spending long amounts of time in bed awake. Dr. Kinn, you, as indicated earlier, are a psychologist. what did Pavlov do?
Pavlov's assistant rang a bell every time to feed Pavlov's dogs. And then Pavlov noticed that every time the assistant rang the bell, even when food was not around, the dogs salivated.
Exactly. And so what would a person do if their boss came to them and said, I'd like you to salivate right now?
Well, if we're in the military, we would probably go ahead and salivate on purpose.
Okay.
Because that's what we are rule followers.
Okay. Well, you're better than some. I think a lot of people would say I can do push-ups, I can run around the building, I'll write a memo, but
okay.
I don't know how to salivate on command. But a point being that those dogs didn't raise their hand. They didn't say, hey, teach me how to salivate on command. But they got conditioned.
Yeah.
So they were being fed, and then later they were being fed, and a bell was being rang, and then the bell was just ringing, and they got conditioned to, hey, bell means food. So why do I tell that to people with insomnia? Because sometimes their bed and bedroom, and that time of day becomes associated or conditioned with not sleeping. So then if someone is lying in bed for an hour or two trying to go to sleep every night between 10 p.m. and midnight, then they are essentially conditioning themselves of, hey, this is when I'm awake, this is when I'm thinking, this is when I can't fall asleep, this is when I get frustrated. And earlier we talked about those alerting parts of the brain. That's then reinforcing to those parts of the brain, hey, this is when we're awake, this is what we do right now. So obviously, 10 o'clock at night, you want the sleep-inducing parts of the brain to be working and highly working and working effectively, not the wake parts. So therefore, stimulus control, the stimulus we're trying to control then is the environment, the bed, the evening, the timing of day. And so people, we're not going to give them, as noted in an earlier podcast, we don't have a great sleep med. We're not going to give them something that's just going to knock them out. Instead, we're going to work on the non-medication treatments, and we're going to try to link the bed and the evening with sleep. Will they sleep immediately? No. So if they're not sleeping after an estimated, because we encourage not clock watching, we discourage clock watching, they're estimated 15, 20 minutes, not sitting there with a stopwatch running, not with an Excel spreadsheet tracking this.
Right.
Estimated 15, 20 minutes and you're drowsy, of course, stay in bed. Want you to associate that with sleep. But 15, 20 minutes and more alert, more awake, not likely to fall asleep in the next few minutes, rather have the person up out of bed, preferably a different part of the house, and preferably or strongly encourage not alerting daytime wake activities, not cleaning the house, not watching TV. As we indicated earlier, light's a problem. So
not doing work or studying, I'm assuming.
Correct. Not smoking, which obviously itself is alerting the activity and then the nicotine. So my favorite activities, and people may roll their eyes and grind their teeth, but my favorite evening activities for this are just looking out a window or just looking at a painting or picture. But retraining brain that bed and evenings for sleep and that time of day is for sleep. Then, when their eyes are heavy, return back to bed and repeat and try again.
And if windows and paintings don't do it for you all, something else relaxing. And that's why it's important to practice relaxation, meditation, mindfulness during your waking hours so that you already know how to do it at night when you need it.
And not with a bright light.
Right. Well, tell us about sleep restriction. Is that similar?
It's part of the cognitive behavioral therapy for insomnia. But this is, frankly, in an organized way, sleep depriving someone so that they're sleeping efficiently, a high percentage of the time that they're sleeping in bed. So if someone says, I'm sleeping only 5 hours a night, but I'm in bed for 8 hours, then, and this requires a highly motivated individual, then they could consider sleep restriction, which would be spending 5 hours in bed, say midnight to 0500, and do that for a week and reevaluate. And if they are sleeping, say, more than 90% of the time, not Excel spreadsheet, but just, a ballpark.
Estimated, right.
Estimated. I like estimated. Some people do like writing it down every morning. But then if they're sleeping more than 90% of the time, then they would increase their time in bed by 15 minutes. So say they go to bed then at 11:45 and still wake up at 05, including weekends. Reevaluate the next week. If they are sleeping between 80 to 90% of the time, then they would stay where they are. If they're sleeping less than 80% of the time, then reduce the time by 15 minutes. And realistically, it is sensible to write down your efficiency, say every morning, rather than just at the end of the week go, oh, I'm pretty good, or etc. But I discourage people from certainly turning on lights or noting how long they're awake every time if they go to the bathroom, etc. So people can decrease the time, keep the time the same, or increase it depending on how efficient they are, what percentage of the time they're asleep. We never reduce their time below 4.5 hours. So even if someone says, hey, I'm sleeping 3 hours a night, if I'm going to work with them on sleep restriction, I will say, well, then I'd like you being in bed for 4.5 hours every night. And then if you're sleeping more than 90%, you'll increase it by 15 minutes. If you're staying between 80 to 90%, you'll keep it the same. And even if you're sleeping less than 80%, you're still going to stay at the 4.5 hours.
Now, this seems like I don't want to say complicated, but it's definitely something you need to put thought into, of how much you're increasing it in those increments over time. Is sleep restriction something you can only do with a doctor or a therapist?
I'd encourage you to strongly consider doing it with a clinician. Possibly, if you're highly motivated, do it yourself, but I'd be very, very cautious about that. But it's as pointed out, or as you indicated, it's not something you should just do for 2 days and stop and resume for 3 days and stop. There's a lot of data, evidence-based data, that this is effective. I've liked my analogies. I'll stick with one here. If you're my trainer, Julie, and take me over to the gym and my squat form isn't too good, and my ankle flexibility isn't too good, and I'm struggling with weight, you're not going to say, oh, let's add 50 pounds.
Right.
You're going to say, ooh, you're struggling here. We're either going to, at most, stay where you are, or we're going to back off some of the weight till you get this down till your movement's efficient. Same thing with the sleep restriction.
It does seem related to the stimulus control, because you're getting rid of that time where you're just lying in bed frustrated, thinking every minute I'm awake is a minute more tired I'm going to be tomorrow. You're taking that out of the equation, so you're not training your brain to be awake in bed anxious.
Exactly. There are people, you've met them, and some of our listeners, maybe one of them, or they may know someone, that they'll describe being very tired at night, very tired during the day, very tired at night, and then they open their bedroom door, see their bed, and then they're anxious. They're more alert. They're more awake. And so that's in kind of this Pavlovian response with a stimulus control, where they've trained themselves, their bed and brain, to be more alert. Some people will report, I really struggle sleeping in my own bed, but when I go to the field, or when I go to a Holiday Inn, or when I travel, I do great. So I can sleep on a rock in the field better than I can in my own bed. Some people we see in the sleep lab, they'll report, hey, that was a great night's sleep. Yeah, they had wires hooked up from head to toe, but they said they slept better than they usually do at home. So that's suggestive of a training component to their insomnia. Right. Not that they raise their hand and say, I want this, but suggestive of that.
Okay, well, let me summarize. Tell me where I got anything wrong. Starting with caffeine, thank you for helping us understand that really trying to get to a point where you're drinking caffeine before lunchtime or before noon is probably a good goal, but getting there gradually makes sense. And that it really can stay in our system between 3 and 8 hours because of the half-life that it's got. So everyone's a little different there, and it's good to try for a few weeks, very slowly titrating down. It's more components of CBTI you reviewed for us: stimulus control, training ourselves to not be activating our brains right before bed. And also you told us a little bit more about sleep restriction, which I think is probably a good lead into recommending that folks meet with providers to talk about this. Like you mentioned, sleep restriction is probably something that's best done with a clinician, although, like you said, a very motivated person could probably do this on their own as well. We also learned that you love analogies, and apparently what's relaxing to Dr. Olin is looking out a window. So thank you for sharing that with us as well. Is there anything I got wrong there or that you'd like to add to?
No, I couldn't have said it better.
Okay, perfect.
Especially the window part.
Yes, windows and paintings, now we know. Thank you so much for joining us today. A Better Night's Sleep is produced by the Defense Health Agency. You can get in touch with us on Facebook and Twitter at Military Health. Thank you so much for rating and subscribing us on iTunes or wherever you get podcasts. Be sure to check out our other shows like The Military Meditation Coach and Next Generation Behavioral Health.